thanks to Breaking Convention for allowing me to come back and share some of the work we're doing, and try to give a little update. It's going to be a bit of a potpourri of different things for depression. Some of it old stuff, but also some newer stuff. So yeah, I have a few disclosures sitting on the slide as well. I'll go directly into it. Go back in time to one of our the first trial we did, and actually the first trial that was done in the modern era with any psychedelic intervention for depression. It was a psilocybin trial using what has become sort of standard dose, both from this and other trials for other indications around that time, 25 milligram, to, in this case, in an open label proof of concept design, 20 patients with moderate severe treatment resistant depression. So all that is kind of old news. It was at that point based on old data from the 50s, 60s. It was based on our findings in the brain in healthy people, where we saw some changes that sort of fitted into the line of evidence of how it might actually theoretically, based on the brain data, be supportive, meaningful to test in depression again. It was also based on some of the Johns Hopkins work from modern era, seeing these transformative experiences, an increase in well-being in healthies, which is a bit interesting in the context of what I'm going to talk about in the end, where we step into DMT world as well. So I'll both be talking about psilocybin and DMT. So that I already mentioned. These are the main results. Again, a bit old news. Sustained effects in this group of 20, again without any control condition. And also association between the profoundness, the nature of the experience, and the clinical outcomes. And that has been seen across tons of different trials. It's not necessarily causal. It's an association, but it is quite remarkable and interesting that has been seen in all these trials, this relationship between, in particular, the peak element, so the mystical type experience, and clinical outcomes, in this case, the depression outcomes. So all that, in a way, because it was the first of its kind in modern era, obviously inspired quite a lot more work, including some companies to step into this space and scale it up, including Compass, not just based on this trial, but it played a significant role. So that's why I start here. And then also because in this conference, I've already heard a few times that people are questioning meaningfully, critically, saying, yeah, but what about this is artificial, it's synthesized psilocybin, and it's not in an ecologically valid form. It's inside a clinical lab space and so on. So I also in this talk included, in order to not necessarily meet those critiques, but also show that we also, both us and others in the space, obviously collect data more naturalistic, a bit also what Anne was referring to, and we have also done that and focused in naturalistic perspective online surveys on effects of these experiences on depressive symptoms. And when we did that, we looked at our survey data and saw that most people were in the mild moderate range, not very many in the severely depressed range in these online surveys that we did, and most of them were using psilocybin and LSD for the planned experiences. And then we were collecting data before, during, after they underwent these experiences. And what we saw there was good effect sizes, decreased in depressive symptoms, decreases in anxiety. So to the left you have QIDS, which is a depression measure, self-rated, validated depression measure. To the right, Spielberger anxiety, so an anxiety measure, and basically mimicking some of what we are seeing also in lab clinical proper studies. So just to add that in there. Then the logical next step was basically, in a way, what Compass did, which was testing different doses, because it's so difficult to placebo control, as we all know, and we have heard also at this conference, full dose psychedelics. So therefore, a logical thing would be, and that's also what FDA supported and endorsed, was to test 1, 10, and 25. So 25 being this full dose. So instead of us also doing that, we were like, what could we do as an interesting comparison, and it was obviously led by Robin Carhart, who is now unfortunately over in the States at UCSF, and we decided to compare psilocybin to escitalopram and SSRI. And one of the reasons for that was mechanistic. We wanted to try to get to some of the potential mechanistic differences between, because when you think about conventional pharmacotherapy with SSRIs, they release serotonin and widely stimulate different targets in the serotonin system. And some of the effects are mediated through a receptor called the 1A. And that is then believed that the actions via that receptor is reducing stress and emotional responsivity, and also decreasing impulsivity, aggression, anxiety, and so on. But that also comes with a potential bill in terms of that patients sometimes experience some blunting. The 2A receptor, where the classic psychedelics work by stimulating that more directly, that receptor leads to reductions in rigidity and in flexible thinking and perseveration and so on. So two different mechanisms that both lead to improvements of mood disorder symptoms. And this is just some data. I won't go into detail, but basically confirming that, yeah, it's a real thing. People do sometimes, some patients do feel blunting, get blunted as side effects from SSRI treatments. So we compared a gold standard, well-performing in the SSRI space, escitalopram, which is also very selective. So in a way, probably a more fair comparison because it's very serotonergic as well. Like the psychedelic, and so 6 weeks of daily escitalopram, and in the other arm, people were randomized to either that or 2 sessions with psilocybin, full dose 25, 3 weeks between, and then daily placebo capsules. So that was the design of that study that was published a couple of years ago now. Main results here, you can see that the primary measure quits, which was also the one from our previous trial, but it was in a way they were added in 3 other depression measures. So Hamilton depression, Madras, and BDI Beck's depression, 3 other measures. And when you look at to the right hand side, you can see that the green, if it's green and to the left, then it's statistically significantly favoring the psilocybin condition. And that was the case for all outcomes, apart from the predefined primary outcome, quits. Brandon Weiss, who's here at the conference, a great postdoc in our team, he's coming out now with a very interesting paper where he's dissecting these different measures. What is happening with quits? Why is it performing differently? And there are some test, retest, and the way that a composite measure use in that scale that might explain some of these differences, and why quits actually didn't turn out to statistically differ the 2 conditions. So we see fast onset, we see significant, as one example of the other measures in the trial, significant separation favoring psilocybin in the well-being outcome, and also both treatment response and remission rates significantly stronger in the psilocybin condition. Roberta and Murphy and Johnny Martell yesterday gave a presentation showing some of this work that Roberta first authored the publication on, looking at where you can both see that the therapeutic alliance played a mediation role in the data, so had an impact on the outcome. So the better therapeutic alliance, the greater emotional breakthrough through the drug sessions, and better improvements of depression severity and COMPASS data, showing quite similar, but there are some statistical differences when we go into sort of mediation pathways, but look actually pretty similar to what we found in our data set. In terms of personality, you might remember that openness has been shown to increase in a range of trials, both in healthy and also in depression early on. We did not see any differences between escitalopram and psilocybin conditions in this trial with regard to changes in measures of personality, apart from trait absorption increasing more in psilocybin. So in a way, not really refinding that openness might be a bit of a specific selective feature of the psychedelic intervention, because some of the others are expected. It's expected that neuroticism goes down if you treat depression, no matter how you treat it. So that's not surprising. We would have expected openness to specifically change more, increase more in the psilocybin condition. That was not the case in this study. Um, and we did MRI in both of the trials I have explained, and some of you heard about before. Both of the depression trial we have done at Imperial. What is interesting is that when we do modularity analysis, which is an fMRI sort of global measure of connectivity in the brain, we see that specifically in the psilocybin condition, in two complete separate trials with different time points of the MRI. So one was 1 day after in the first trial, the other one was 3 weeks after the second full dose in our second trial. And when we look at that data, both trials are seeing this decrease in modularity, which is increased in global functional connectivity. And we can see a relationship between those changes and the treatment outcome. And we didn't see any of that in the Escitalopram arm. So in a way, it was a mechanistic study mainly, and we found some interesting potential suggestions of what might be different in terms of brain mechanism in this trial. In terms of when we post hoc look back at the data and scrutinize the data, we could see that people who had to come off the SSRIs before entering the trial, antidepressant, it could be SSRIs, NRIs, if they had to come off and be weaned off, tapered off the medication in order to be randomized and go into one of the arms, then they did worse on the psilocybin and better on the Escitalopram compared to the group as a whole. So it was 20 of the patients who, so a third of the patients, there were 59 in total, 20 of them had to be weaned off, and you see zero separation between the two treatment effects. However, you see very significant changes also with this quits measure that didn't separate in the total group, and you see a clear separation when people just came in without having to be tapered off because they were not on any antidepressant. It's not that they were not tapered off and stayed on, they were just not on any antidepressant. So in a way, that suggests that it might be a bit tricky to what to do if people are on SSRIs. Do you taper them off? If this is going to be seen in other samples, we don't think that Compass is actually seeing that in their data. So it's a bit puzzling. However, that we then see it. But definitely it needs to be solved. What do we do with the SSRIs? And in MDMA work from MAPS, they have also seen issues that people haven't responded that well in a small sample when they had to be tapered off. So similar issues. However, more novel data from Basel group, they have tried to give SSRIs to see whether that. So then the question is, if it's a problem to taper people off, should people then stay on? And then you add MDMA or you add psilocybin, as you can do with ketamine. Can you do that with psilocybin, for instance? It's a really important question also for practicality. What do you do out in the clinical world afterwards? And now there's a bit conflicting data at the moment, I would say. So the Basel found that in healthy, if you give people SSRIs and then psilocybin, it doesn't seem to be an issue. People still have the same subjective experience and so on, but they only gave it for 2 weeks and in healthy people. They are now repeating that over 6 weeks in healthy people, which is going to be even more interesting and important work from that lab in this regard. And Compass also in a little group of patients, they let people stay on SSRIs and they also saw fine response in the same range as they saw in the entire larger study. And then MAPS are looking into, again, keep people on, which is even more tricky because they work on the same target on the serotonin reuptake side. But if they maybe can overcome it by giving higher doses of MDMA, maybe people can stay on. We have then survey data again that we have scrutinized and looked at what, if we look at this people who were reporting to be on an SSRIs and the people who weren't and tried to match the groups for, how depressed they were and other parameters. And when we do that, we can see a reduction in the subjective experience. And quite interestingly, we see it specifically with the mystical type or psychological peak measures. We don't see it with the visual. And that to us suggests that actually it might not be that it's just a biological thing, maybe downregulation of receptors. It could be that it's actually a blunting effect. So people can't access that psychological peak, because otherwise you would imagine that it should also affect the more perceptual changes. And it didn't in this study. So I would say jury is still out. But again, I mean, all this might speak to blunting of SSRIs, blunting effects. Then what about the follow-up? So far, we've only seen the data at the 6-week time point. So after 3 weeks, 6 weeks of SSRIs, or 3 weeks after the second full psilocybin dose. What about the 6 months follow-up? What we see there is sustained effects, but we see sustained effects in both arms, which is, again, interesting, a little bit surprising. And we then looked at, what did people do in this 6 months follow-up period? Did they go to retreats in Holland and take psychedelics if they were disappointed by being in the SSRI arm? What did they do? And we don't really see any differences in what people did in the two arms, and therefore we cannot explain from behaviors in the 6 months follow-up why both arms are improved equally at the 6 months follow-up. This was shown by Bala-Shigeti yesterday, so some of you saw it. It's just to say it's one of the critiques or potential critiques of psychedelics. But it's all driven by expectancy. We actually, in our sample here in this study, we did not see that expectancy effect, or rather we did, but we saw it in the Escitalopram arm. So we saw that the more people expected a positive outcome from Escitalopram, the more they got it. But actually that relationship wasn't there for psilocybin. A little bit surprising, but also comforting for the psychedelic development. Whether that's going to hold in other trials, what Compass are seeing, we don't know in their larger trial. Other things, again, a bit speaking to this, are we putting the lid on or taking the lid off? So the blunting, a bit lid on, SSRI side effect, psychedelics taking the lid up and opening up to the world and your emotions. And this is also pointing in that direction. Again, Tommaso Baba from our team has published this relatively recently, where a decrease in rumination and thought suppression, sort of a maladaptive defense mechanism, thought suppression, those two features are reduced with psilocybin, but not with escitalopram. So speaking to potential mechanistic differences, more psychological. And here you also see that up in the top, you see ability to cry, ability to feel compassion, ability to feel intense emotion in particular is increased after psilocybin, but not at all to the same degree with the SSRI. So again, suggesting some kind of the lid being taken off with the psychedelic intervention. This is emotional phase, amygdala responsivity in the brain, which is a classic way of studying the brain to the brain's emotional responses, in this case, to different emotional phases. And what we can see is that there's reductions of the emotional responsibility to fearful phases following the SSRI, so the escitalopram, but not after psilocybin. So again, some lid being put on by the SSRI, but doesn't happen in our data here with the psilocybin. So all pointing in the same direction, looking at different factors from the trial. And this is just a little overview. It's not just depression that is being studied and now has been measured and specifically studied in a range of trials. Now also recently on a poster, bipolar type 2 depressive state, also tested in a small sample with psilocybin, looking good and safe and with good efficacy and good safety there, and a range of other indications that I won't go into. We are studying currently some of them, including OCD. And here the Compass, just for completion, the Compass data 233, so large sample, again supportive of the same narrative, that good response, good treatment response, and sustained after 3 months, significantly better for the full dose 25 compared to 10 and 1. And also not just in our trial, we saw, as you saw the very first slide, where you saw quite sustained effect after a single intervention. that is also seen after 1 or 2 interventions across a range of trials, that there are long-term sustained effects for weeks and months across trials. And overall, when we try to really create the overview, as I wanted to do for this talk, this is something that Brandon has done, Brandon Wise again, for a review, a textbook chapter that we are coming out with in a book by Phil Cowan and Trevor Sharp that is coming out relatively soon, where we are trying to review some of these things and specifically discuss psychedelics for depression. And we can see that the effect sizes, which is a measure of how strong are these treatment effects, and we can see really quite good, but with variation. And actually, ours with quits is the one hitting the rock bottom, because you saw that measure didn't separate well, and that's the measure we have used here. But you can see that overall effect sizes of larger sizes, both when you look at within and between condition, than what is seen in conventional pharmaco and talking therapies. Then to something more new, and that's the small pharma DMT trial, where I was the chief investigator at a trial that was sort of led and funded and sponsored by the company Small Pharma, looking at intravenous short experience DMT, so a 20-minute or so experience after a short infusion over a few minutes of the DMT, and people were then randomized to that or to a placebo condition with the same sort of preparation, guiding music, and happening in the room. And then after 2 weeks, assessment of the depression measures, that was the primary outcome. Then the blinding was taken off, and people were then offered another treatment if they already had DMT, so they would get a second dose. And the people who got a placebo first would then be offered a DMT session. So that's what happens after 2 weeks. Then it's unblinded, and people are getting DMT again here. And what was shown there, this is over the first 2 weeks. You see that the people who got the DMT first, they drop in depression severity actually pretty in a quite good size. So almost 13 points on the MADRS, which is the most gold standard sort of clinician rated assessment tool for depression. And you do not see at all the same improvements in the placebo condition. So that was sort of the main outcome at 2 weeks. That was a positive finding, so significant improvement and better in the DMT condition over placebo. And then when you look at the rest of the period, you can see that then the people in the dark blue, then they were then offered after 2 weeks the DMT, and then you can see then their depression scores dropped, and sustained effects, as has seen with our data and with Compass data after 3 months also with, and that's quite interesting. So here you have a short experience with DMT, and it actually looks the data pretty similar to what we're seeing with the 4-5 hour psilocybin experience. So that is actually quite exciting. Also, treatment response, which is more than half, 50% reduction of the depression severity, and remission, which is going under a MADRS score of 10, is in the range of 50, which is very good, both response and remission rates. And interesting, this is the most novel aspect of it. We now have the 6 months follow-up, partly thanks to Ashley, our moderator, who's helped collecting that. And we see also good remission rates at 6 months in this study. I think I'll skip that. That's just that some of the other measures, well-being, anxiety, also improved alongside the main MADRS outcomes. Then I just thought, in my title, it's all about psychedelics. And I was like, can I put this in? Is it psychedelics? Not really, but almost, because the PET tracer we used is kind of a psychedelic. It's just in a very tiny dose and radioactive version. So I thought I can put it in here because it's about depression, and we have some other interesting findings. So I also felt I'm going to show something else that is relatively new and exciting, at least we think. So we have developed a PET measure, so positron emission tomography measure, where we can label a tiny dose of a very selective serotonin 2A agonist, so a psychedelic called Simpi 36, or it's an NBUM, if some people know those drugs. And we did that before and after giving people amphetamine to release some serotonin. And we did that in healthy people, and we compared it to and did the same thing in people with depression, some people with Parkinson and depression, some people just with depression. And what we saw there was that the release of serotonin was significantly diminished in depression. So this is not specifically about psychedelics, but it's mechanistically interesting about depression. Trying to understand the neurobiology of depression is the first method ever to actually be able to measure serotonin in the living human brain. So when you've heard about the serotonin hypothesis, it actually extremely indirect evidence. This is the first more direct evidence that actually supports the serotonin hypothesis. There's some reduction in the functioning of the serotonin system in depression. Then, just for the last bit, a little bit about microdosing, also inspired by a press conference yesterday where we were debating it lively. What is it? Is it homeopathy? I would say that's the easiest thing to say. It's not, because there is actual drug in what people are microdosing on. There's proper molecules in there, and they actually, we know from PET occupancy measure work that we can see that the range of drug doses that people use to microdose, they actually have significant occupancy on the 2A receptor. So theoretically, there could be pharmacological action of the drugs in the dose range used for microdosing. But is it that it's an extremely hyped thing that really drives the effects by having something that is really popular, very, very hyped? So that's sort of a blood type diet kind of scenario where everybody did that and probably had effects of it, but there wasn't real effects of it. So, but if it's hyped enough in a period, then it drives the placebo. Are there real effects, or is it that microdosing only works if it's combined with something else? Talking therapy, environmental changes, lifestyle changes, other things that could be beneficial. Is it more like a plasticity inducer where you need something else to actually make it work? I think we are currently, floating around over there in the knowledge, I would say. Some people are very convinced, also colleagues, also at the press conference yesterday, that it works. And I'm not saying it doesn't work. I'm just saying let's cautiously assess the evidence. So we can't do meta-analysis because there's not enough real trials. It's a random mess, not a random mess, but it's a mess of different methods used. So instead, we have been trying to figure out, and people in the team, including particularly Ola Malin, has done a great work now trying to figure out how we can actually do it in practice, this idea of trying to visualize all the evidence for microdosing, and that we are now getting very close at being able to. So this, what I will show here, please don't maybe take pictures of it because it is work in progress, and it could be that they will be moderated a bit before this is the official version of the data. But basically, again, it's about this talk, depression. What about, does microdosing seem to have potential mood improving effect, anxiety, depression, well-being? Is there any data to support that microdosing actually work? So we went through all the data, divided it into 4 sections. So affective, which is mood disorder data, cognitive, other psychological, and somatic. And then we labeled the data green if it's significantly statistically supported beneficial effects of microdosing in any of these categories, and red if it was sort of in an adverse event direction rather, and then white neutral if there was neither of the directions, light green if it's on the positive direction but was not significant, light red if it was negative direction but not significant. And we then took all these studies and we ranged them based on the quality of the evidence. And we divided them into the different categories: qualitative studies, retrospective study, case control and comparative studies, prospective, and RCT, so randomized clinical trial setup design of the trials. And when we do that and we plot it, and this is where maybe don't take photos. So this is the affective. So this is the mood symptoms, and you can see it's very green. So this does support, if you look at the data here, it does support that, microdosing seems to be doing something significantly positive for mood features, okay? So that's great. The issue is that we are actually down in the bottom of this Christmas tree of evidence. So if you take the entire, all the different categories and all the different data categorized into the different kinds of trials, and they're all ranked depending on how strong they are designed and what is the ranking in terms of level of evidence. When you move up in this Christmas tree, you see that the colors are disappearing. And that basically says that, yes, if you look down there, you will say, yes, microdosing works. If you look up there where it's controlled and you have placebo integrated into the trial design, it doesn't survive the improvements beyond placebo. So far. Doesn't mean that it won't happen, and it hasn't been done that much work in depression yet, so it's going to be interesting. So it's not that we're saying it doesn't work, but so far it's not convincing. And just to show how is that possible that it looks like that there, but not like that there. One of the reasons we can use our own trial as an example, Ballas's self-blinding trial. If you look here, you see nice improvements in our survey as well of microdosing, but you see also nice improvements of the placebo condition. And here we can see that if people think they take placebo, but they actually took a microdose, it doesn't work very well. If they take microdose, and the other way around, if they wrongly guess it was a microdose and it actually was placebo, then it does work. So that's why it's possible to have this confusing thing about where you are in the hierarchy of evidence. So it's important that evidence is not evidence. We need to be critical and assess it critically. So that I will end on that note, and thanks for your attention.